Good evening, ladies and gentlemen. Can you hear me?
Yes, ma'am.
Yes.
Yes, ma'am.
So let's talk about whether it's insulin or metformin in pregnancy. So for me, it's going to be insulin. And why is that? Because it is safe for fetus and neonates, and it achieves excellent glycemic control, and it's very easy to administer. Likewise, what people think it is, and it gives flexibility when dietary modifications are needed. So I'm going to prove these points in the next few minutes for insulin in pregnancy. First of all, may I tell you why we treat diabetes in pregnancy? Gestational age birth weight. It increases neonatal and pregnancy complications and increases the risk of long-term maternal type 2 diabetes and abnormal glucose metabolism in childhood, which is due to fetal programming during the pregnancy. And to prevent above complications, diabetes in pregnancy should be treated meticulously. I think all the guidelines across the world agrees for very tight glycemic control, and HbA1c less than 6. It can be achieved without any hypoglycemia. So you can understand why we need to control the diabetes in pregnancy very strictly. And this has been looked into by systemic review and meta-analysis in looking for benefits and harms of treating GDM. And they could only find that very short-term harm of treating GDM, that is, that increases the demand for services, which we all know that it will require a lot of multidisciplinary teamwork. So management of diabetes in pregnancy includes lifestyle intervention in 80 to 85% of the mothers, and only 15 to 20% will need the pharmacological interventions. So let's talk about the pharmacological intervention in diabetes in pregnancy, and insulin is the gold standard first-line recommended treatment. And metformin and glyburide are not recommended as first-line agents in many guidelines. And let me brief you why it is so and why insulin is the gold standard in treating diabetes in pregnancy. The first question, is insulin safe in pregnancy? The currently available human insulin preparations does not cross the placenta, and the analog insulin preparations have also proved their efficacy and safety as well. So these are the few studies that they have done for glargine, Lispro, Aspart, and Determere, looking into these medications, and they do not cross the placenta, and they are very safe in pregnancy. Is metformin safe in pregnancy? It crosses the placenta. And even so, the metformin is shown to have higher concentration in fetal circulation when compared to maternal circulation. And this has been looked into by population pharmacokinetics of metformin, led pregnancy studies. Many studies showed that it crosses the placenta. So if it crosses the placenta, can it harm the baby? So this was studied in few trials. One is the MIG trial, in metformin in gestational diabetes trial in New Zealand and Australia. And they have randomized 750 women with GDM requiring either metformin or insulin. And the pregnancy outcomes were similar between the groups, where even the gestational birth weights were the same. So contradictory to what people think insulin causes higher weight gain, but this study showed it is equally in the pregnancy outcomes. But they could find that metformin patients who were on metformin delivered 1.7 days earlier to patients who were on insulin, and they had increased rates of preterm birth. So this was a risk factor, risk of patients being on metformin according to this trial. The second question, can insulin achieve the glycemic targets in pregnancy? Same goes in this trial. 46% of the patients who were in the MIG trial on metformin had to be supplemented with insulin. So metformin alone was not good enough in controlling the required glycemic targets. So insulin, when used carefully according to patients' sugar profiles as either basal bolus or prandial cover, can achieve excellent glycemic control of HbA1c less than 6, better than metformin. The third question would arise, are these medications safe for offspring, and what are the long-term outcomes? So this has been looked into again by very few studies, and one is the MIG TOFU trial. The same trial, they have looked into their offsprings at 2 points, one at a 2-year follow-up, then the 7 and the 9-year follow-up. The first 2-year follow-up study showed that the body fat, total body fat showed no difference between the treatment arms, either metformin or insulin, but in the metformin arm, the children had upper arm circumference, which were larger, biceps and subscapular skin folds were greater in offsprings compared to the patients who were on insulin. So this raised the question whether metformin exposure in utero was associated with a different pattern of fat deposition, or whether this would persist or be associated with differences in insulin sensitivity, which the answers we still don't know. They showed similar results. There's no difference between the total and abdominal body fat percentage, but the 9-year follow-up, the offsprings of women randomized to metformin were larger. They had about 6 kg in difference in body weight. They had increased waist circumference, increased arm circumference, and marginally increased BMI, p-value of 0.45, than those whose mothers had been randomized to insulin. So out of this trial, still the safety of metformin for offsprings were unclear. So we still don't know what metformin can do to the offsprings as well. And this has been looked into by systemic reviews and meta-analysis, and following exposure of metformin in the intrauterine life, neonates were significantly smaller than the neonates who had insulin, but the metformin exposed children appear to experience accelerated postnatal growth that results in heavier infants and higher BMI. So that means children are born smaller, but they outgrow and they accelerated postnatal growth after the delivery. So finally, to conclude, ladies and gentlemen, insulin in pregnancy is very safe, is efficacious, and there is difference or even small neonatal birth weights, and offspring data is satisfactory. So I think insulin should be used in pregnancy to have the tighter glycemic control we want during pregnancy. So I hand over to my counterponent, Dr. Gupta now.